conditions that can affect the vulva in postmenopausal women. We have discussed before that estrogen deficiency leading to atrophy and dryness is the commonest condition. Contact dermatitis, both allergic and irritant, is probably the second commonest. But there are specific skin conditions, particularly lichen sclerosus and lichen planus, that can affect the vulval skin. Here we will discuss lichen planus. Lichen planus is relatively rare but can affect the vulval skin. The difference between lichen planus and lichen sclerosus clinically is that lichen planus affects the vaginal mucosa and other mucosa as opposed to lichen sclerosus, which is mostly on the skin. Lichen planus is thought to be an autoimmune T-cell mediated condition that results in chronic inflammation of the skin, the nails, the oral and the genital mucosa. In postmenopausal women, the average age of presentation is about 57 years. There are three main types: erosive lichen planus, classical lichen planus and hypertrophic lichen planus. Erosive lichen planus is the commonest type. It generally starts at the introitus with an erythematous erosion, well-defined, with a well-defined raised whitish edge, and this often extends into the vagina. The classical symptoms are pain, superficial dyspareunia and postcoital bleeding. It is important to recognize these lesions, particularly the vaginal involvement, early so as to prevent gross scarring and loss of architecture. It is therefore also important to treat it early. Classical lichen planus generally is found in the anogenital keratinized skin as raised papules. They often resolve spontaneously. Hypertrophic lichen planus is found generally in the perianal skin as plaques, raised thickened plaques. They're very rare. Regarding diagnosis, clinical diagnosis is often the mainstay. However, biopsies may be indicated if there is any doubt about the diagnosis or the differentials or suspicion of malignancy, and referral to secondary care is appropriate. A proper explanation to the patient and preferably written documentation or websites are important. Irritants should be avoided and emollient soap alternatives should be used. Topical ultrapotent corticosteroids, namely clobetasol propionate 0.05%, ointment twice weekly for 3 months is often the first line treatment. There is only one randomized controlled trial, and therefore there is usually no proper consensus. However, with this treatment, there is evidence that the symptoms get better in 75% of the patients, and there may be complete remission of the acute symptoms in 55% of the patients. Long-term maintenance with a weaker steroid twice weekly or short-term potent steroids may be indicated. Very rarely, surgery may be needed, and at least an annual follow-up is essential. Conversion to squamous cell carcinoma is rare, but some studies suggest it can be up to even 3%.